Good evening to all respected professors and my dear colleagues. Today I am presenting topics on monoarticular arthritis, the synovitis and synovial fluid analysis. First we start with monoarticular arthritis. Arthritis is the inflammation of the joint based on number of joint involvement is divided into monoarticular, oligo and polyarthritis. Monoarthritis is single joint involvement.
Mohan, you put your video up.
2 to 4
your
joint
bandwidth is
involvement.
low.
Polyarthritis is
Mohan,
more than 5 or more
Mohan,
than 5
Mohan, wait.
joint
Mohan, wait.
involvement.
Mohan, wait.
Duration in
Mohan, listen.
less than 2 weeks duration.
Mohan, listen.
I think his net is not working, so he's not getting.
I think he is reading from some printed material. Otherwise, we are asking him to stop. Mohan,
Most of patients with musculoskeletal complaints suffer from mostly with the back.
I think
Yes, sir.
network problem. He's not getting. Mohan, can you listen?
Yes, sir. I'm audible, sir.
yes,
I'm
now you are
audible, sir.
audible. Keep your video off and then speak. Okay. And speak little close to the mic.
Based on duration of the arthritis divided into acute and chronic arthritis, sir. Patients with musculoskeletal complaints are suffering from mostly with a back pain and with osteoarthritis in 31% of the cases. In soft tissue rheumatism like tenosynovitis and bursitis, tendinitis, into incidence is 9% only. Most of the arthritis by physical examination and laboratory test. Origin of the pain is from the joint. From the joint, mostly synovium, cartilage, and capsular structures are involved. Adjacent structures are pain occurs due to bursitis and tendinitis. We must to differentiate from the true intraarticular or peri-intraarticular pathology. In true intraarticular pathology, both active and passive movements are painful. In peri-articular pathology, mostly active movements are more restricted than the passive movements. Monoarticular arthritis is presents with the pain and swelling and stiffness of the joint with limited motions. With increased rise of temperature, tenderness and crepitation present with increased deformity, increased arthritis condition presents with deformity and instability. In monoarticular arthritis condition, differential diagnosis considerations occurs due to infection, crystal individual arthritis, due to gout monosodium urate crystal deposition, and in calcium pyrophosphate dihydrate deposition due to pseudogout. In traumatic condition and hemarthrosis in case of hemophilia, sickle cell anemia, osteomyelitis and periarticular symptoms in bursitis and tendinitis cases. Ruptured Baker's cyst thrombosis, pigmented with villonodular synovitis and mechanical derangement foreign body can appear like a monoarticular arthritis. First, we discuss with septic arthritis. Septic arthritis is inflammation of the joint due to infective organism. It occurs by hematogenous route or direct inoculation due to trauma or penetrating wounds, or contagious spread from the metaphyseal osteomyelitis and extraskeletal structures with ligamentous and septic arthritis most commonly in weight-bearing joints involvement. Mostly knee joint is involved. Next is hip joint is involved. Gonococcal arthritis, disseminated gonococcal infection presents with a triad of vesiculopustular skin lesions, tenosynovitis, and arthritis. And non-gonococcal infections are mostly with the staph aureus, with some exceptions. In the less than 2 years old, Haemophilus influenza is most common cause of septic arthritis. In young adult and a healthy active patient, Neisseria gonorrhea causes septic arthritis. And early prosthetic infections caused by staph epidermidis and late prosthetic infections caused by anaerobes and gram-positive co-cases. In rheumatoid arthritis, staph aureus causes infections. In systemic lupus erythematosus, Salmonella species causes infection. In septic arthritis, in early stage of septic arthritis, synovitis occurs with purulent effusion. Next, artery cartilage is damaged with the bacterial and cellular enzymes. If infection is not treated, then cartilage may be completely damaged with bony ankylosis. Fibrous ankylosis occurs in the TB arthritis. Predisposing factor for septic arthritis are artificial joint implants and bacterial infection somewhere in the body as a skin infection. Chronic illness as diabetes, rheumatoid arthritis, and sickle cell anemia increase the rate of septic arthritis, and IV drug abuse and immunosuppressive medication using increase the risk. And recent joint trauma or post-operative conditions are sometimes increase the septic arthritis condition.
Mohan, what do you mean by IV drug abuse? IV drug abuser, how it appears?
I mean,
How it will cause monoarticular arthritis?
by involvement, septicemia in the blood causes.
I think you have just copied the things. You have not read it and understood.
So question for next time you will answer in short. Okay, why there is monoarthritis in IV drug abusers? Okay.
Yes, sir. Yes, sir.
And go ahead.
And we must be evaluated by blood investigations. In elevated results are elevated white blood cells with increased ESR and CRP. Sometimes blood cultures are positive with infective organism. Initially, radiologically, initial septic arthritis is normal with after the articular joint involvement, joint space is reduced. In case of minimal fluid effusion, we go for ultrasound and synovial fluid analysis tells the gram staining and the cultures of the synovial fluid. And the treatment of the septic arthritis is first priority to aspirate the joint and examine the fluid. Treatment should be started without further delay. With the general measures, analysis and splintage in the functional function to decrease the deformity. Before culture sensitivity report comes, we start with the empirical antibiotic therapy first. Then after the report, we go with the definitive antimicrobial therapy. If the medical treatment is failed, then we go with the surgical adequate drainage and the resection of the infected tissue is gold standard. Tubercular arthritis causes in 1% of the all tuberculosis patients or 10% of the extrapulmonary cases. Is always sequelae to the pulmonary or extrapulmonary TB. It causes granulomatous infection with tissue necrosis and caseation. Synovialism is involved. It becomes thick and edematous with marked effusion. Pannus of the granulation tissue develops, causes articular damage, and increase the vascularity causes osteopenia. If treatment is invalid, then caseation and infection extend into the surrounding soft tissue, produce cold lapses. Cold lapses may burst, forming sinus or tuberculous ulcer. And the stages of the tuberculous arthritis is stage of synovitis and stage of early arthritis and stage of advanced arthritis. Advanced arthritis with pathological subluxation and dislocation, and aftermath terminal of grass and arthritis. With TB, tuberculous arthritis presents with the triple deformity of the knee as valgus sectional rotation and flexion of the knee associated with posterior subluxation of the tibia. Acute arthritis caused due to crystal deposition in gout, monosodium deposited. In pseudogout, calcium pyrophosphate dihydrate are deposited. In calcific periarthritis conditions, calcium hydroxyapatite crystals are deposited in the joint. Gout can have low grade of temperature mixed with infection. It raises inflammatory markers with neutrophilia, and the cutaneous erythema may extend behind the joint and resembles the bacterial cellulitis. Majority of the gouty patients have further attacks, and most of the time metatarsophalangeal joints are involved. Trophy can occur in the chronic phase of the gout arthritis. Risk factors are gout. Primary gout risk factors are obesity, hyperlipidemia, diabetes, hypertension, atherosclerosis. And secondary gout risk factors are alcoholism, diuretics, cytotoxic therapy with chronic renal failure. This is X-ray showing periarticular erosions in the gouty arthritis involving metatarsophalangeal joint. Diagnosed with the synovial fluid examination, these are middle or rod-shaped crystals with strongly negative birefringence under polarized light. Pseudogout is deposition of the calcium pyrophosphate dehydrated crystals in the joint. This is the X-ray finding of erosions of the metacarpal hand and the chondrocalcinosis of the large joints. Diagnosed with the synovial fluid aspiration, rod or rhomboid-shaped crystals are present. These are weakly positive birefringence under the polarized light. Pain control and reducing the damage to the joint are primary goals in the gout and pseudogout. We treated with the non-steroidal anti-inflammatory drugs and corticosteroids and colchicine. And definitive treatment is urochlorine and uricosuric drugs like allopurinol, probenecid, febuxostat, and sulfenpyrazole. And traumatic monoarthritis is a rapid onset of monoarticular pain.
Mohan, just do you know how it works?
Sir.
These drugs you have mentioned, uricosuric drugs and colchicine. Mode of working.
Yes, sir. By increasing metabolism, causing ureatic converted into metabolite exciting in the urine. It increases the metabolism, sir, by uricase action, by xanthine oxidase action.
So their mode of working is quite different.
Sir.
Okay. Next.
Thank you, sir. In traumatic monoarthritis is rapid onset of monoarticular pain within seconds and minutes due to the direct trauma or meniscal tear causes articular damage, and the fractures and dislocation causes arthritis condition. Hemarthrosis is hemorrhagic effusion of the synovium due to traumatic cruciate ligament rupture or intra-articular fractures are there. Pigmented villonodular synovitis and bleeding diathesis causes hemarthrosis. Charcot arthropathy is a chronic condition, chronic unstable hypermobile restrictive condition. Causes are diabetic mellitus, leprosy, syphilis, and poliomyelitis and syringomelia. And sometimes seronegative spondyloarthritis, psoriatic arthritis, and reactive arthritis causes monoarthritis, presents as a monoarthritis. Reactive arthritis presents with the triad of symptoms like urethritis, conjunctivitis, and arthritis. In chronic conditions, osteoarthritis and rheumatic arthritis are initially present as a monoarthritis. And synovial fluid analysis should differentiate the non-inflammatory and inflammatory by leukocyte count. In non-inflammatory condition, leukocyte count is less than 2000. In inflammatory condition, more than 2000 cells per cubic mm. Briefly diagnosing the acute monoarthritis scenario with the complete history and physical examination, we have to rule out from the articular and periarticular. If articular pathology is there, then we go with radiography. we see the fractures and avulsions. In arthritis, osteoarthritis and chondrocalcinosis, we go with the complete bed picture count, ESR and uric acid levels. Find out if joint effusion is there, go with the arthrotensis. No effusion, but severe symptoms are there. Then further investigation with CT, MRI, ultrasound to guide aspiration needed. In arthrocentesis, we find crystals in the crystal deposited disease, gout and pseudogout. In synovial fluid, the leukocyte count is less than 2000 in non-inflammatory and more than 2000 in the inflammatory arthritis. If more than 1 lakh in the septic arthritis. If bloody synovial fluid is found, it is mainly due to fractures and infant derangement of the tumors of the joints. Next, coming to synovitis, synovium is differentiated from the mesenchymal tissue around the articular disc. It clears the articular.
Sorry to disturb. Mohan.
Yes, sir. Yes, sir.
You are talking about fluids.
Yes,
one
sir.
thing is there you have not mentioned. If it is septic arthritis fluid,
Yes,
infection, the sugar level is less. Another
sir,
thing,
yes, sir.
do you know differentiate between exudate and transudate?
Exudate is unsterile and translate is sterile condition.
No.
Exudate from the...
It is very important in synovial fluid.
Okay, sir. Okay, sir. Okay, sir.
Take next.
Thank you, sir. Coming to synovitis, first synovium is differentiated from the mesenchymal tissue around the articular disc. It clears the articular surface by 5th month in the utero. Mainly synovial membrane contains synoviocytes. These are required for the nourishment of the chondrocytes and removal of the metabolic products. And synovium histology, it contains fatty and fibrofatty fibrous structures with type 1, type 3 collagen. There are two types of cells, type A cells and type B cells. Type A cells are macrophages with phagocytic action. Type B cells are like fibroblasts with secretion of the hyaluronic acid and protein. Synovial fluid is a clear viscous fluid which does not clot on the standing because no fibrinogen is in the synovium. Normal knee joint contains 0.5 to 4 ml of the fluid. Viscosity depends on the concentration of the hyaluronic acid. Synovial fluid contains 96% of the water and 4% of the solids with pH of the 7.3 and 7.6. Synovitis is the inflammation of the synovial membrane present with joint swelling and inflammatory pain. Causes of the synovitis are due to direct trauma or allergic reactions, exogenous endogenic surfaces, and infections. Septic arthritis condition causes initially with the synovitis. And non-infective inflammatory causes are rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and reactive arthritis, enteropathic arthritis. Degenerative conditions causes osteoarthritis causes initially with synovitis, pigmented velonodular synovitis, and transient synovitis, synovial chondromasis, cartilage metaplasia, and unknown sometimes synovitis with unknown causes. Presence with the synovitis and rheumatoid arthritis and osteoarthritis. Inflammation of the synovial membrane present and with alteration of the adjacent cartilage. Inflamed synovium produces catabolic and pro-inflammatory mediators. The catabolic and pro-inflammatory mediators causes cartilage alteration. It creates a vicious cycle. And inflamed synovium presents with thickening of the synovial fluid effusion and thickening of the synovium with signs of inflammation, redness, swelling, pain, and heat. Involvement of synovium in osteoarthritis is cartilage destruction and occurs in the osteoarthritis. Cartilage degradation products taken by the synovial fibroblast, which increases the T cells and B cells, which cause release of the pro-inflammatory mediators, which cause further damage of the cartilage occurs. With in addition to these cartilage degradation products, macrophages release bone morphogenic proteins, which induces the osteophyte formation. So subchondral bone loss and with osteophyte formation occurs in the osteoarthritis. In rheumatoid arthritis synovitis, in early changes are vascular angiogenesis, vascular congestion with new blood vessel formation. Proliferation of the synovitis occurs in the rheumatoid arthritis. and subsynovial linings are infiltrated with polymorphs and neutrophils. Later that capsular thickening present and villus formation of the synovium, and later cell-rich effusion into the joint and tendons occurs in the rheumatoid arthritis. And the synovitis by doing laboratory investigations, increase leukocyte count and ESR CRP found in the septic arthritis, and by doing microscopy and cultures of synovial fluid, find out in the crystals in rheumatoid arthritis and gout and pseudo gout, we find out the crystals. Radiologically, initial synovitis are normal. After that, with the soft tissue swelling is present, and ultrasound is for minimal fluid and ultrasound guided aspiration biopsy. Synovial histology is the diagnostic procedure in the synovitis condition. Synovial chondromatosis causes synovial effusion. This is a rare benign non-cancerous condition with multiple loose bodies, appears like a snowstorm of the knee. And the secondary, it appears as a secondary weakening of the joint space with the loose bodies undergo ossification, then appears in the X-rays. Synovitis of the knee, radiological findings with separate periarticular fat pad more than 10 mm with obliteration of the crisp posterior border of the quadriceps with displaced quadriceps tendon and patella anterior. Osteoarthritis knee radiological findings are with the joint space narrowing, osteophyte formation, subchondral sclerosis and subchondral cyst. This is the tibiofemoral osteoarthritis and this is the patellofemoral osteoarthritis. Grading of osteoarthritis given by Kellgren and Lawrence. In grade 1, the joint space is doubtful. The joint space narrowing is doubtful with possible osteophytic lesions. In grade 2, osteophytes are definite with narrowing is possible narrowing of the joint space present. In grade 3, joint space is narrowed with multiple osteophytes with some sclerosis and deformity of the bone counter present. In grade 4, loss of in grade 4, grade 3 changes are present with deformity of the joint. Coming to synovial fluid aspiration, synovial fluid composes hyaluronic acid present in the synovial fluid, which is responsible for the increased viscosity and elasticity of the articular cartilage. It lubricates the surface between the synovium and cartilage. Lubricant secreted by the synovial fluid. Major functions of the synovial fluid is reducing the friction between two articular cartilage and the lubrication, and acts like a shock absorber. It supplies the oxygen and nutrient to the chondrocytes. In synovial fluid effusion, we commonly do arthrosynthesis. Arthrosynthesis in the elbow doing at the bare area of the watershed area of the elbow is borders of the watershed area of the elbow are lateral epicondyle and the radial head and lateral border of the electron process. In knee superior anterolateral of the superior border of the patella, arthrosynthesis is done. After taking sample, we send for total microscopic changes and differentiable counts. Macroscopic laboratory testings involves volume of the fluid, synovial fluid. Normally, volume is 0.5 to 3 ml with transparent clear synovial fluid. Infusion bodies are normally not present with high viscosity. Clotting usually synovial fluid does not clot because it does not contain fibrinogen. Using clotting time is 4 to 6 minutes. Normal synovial fluid is less than 3.5 mm. Can be in the inflammatory condition, it can reach up to 25 mm. Normally colorless hemorrhagic condition, it appears like a red brown xanthochromatic. Non-inflammatory condition, yellow clear. Inflammatory condition appears like yellow cloudy nature. In crystal deposited disease, it appears like a white cloud and milky appearance. Inclusions, rice bodies occurs in the rheumatoid arthritis. These are free-floating aggregates in the tissue paper as a rice body. And onconotic states are from joint processes appears like a ground pepper. And mucin class test is normally 4 to 6 centimeter. When 2.5% acetic acid is added, synovial fluid will form a clot with clear fluid, surrounded by clear fluid. And normal synovial fluid does not clot. In case of damaged synovial membrane and traumatic tub, the clotting occurs. Ropes test is for estimation of the hyaluronic acid. By adding acetic acid to normal synovial fluid, causing clot formation. By compactness of the clot, we knowing the hyaluronic acid content. By solid clot, in case of good hyaluronic acid content, with no clot is there with poor hyaluronic acid content. And synovial fluid aspiration microscopically with cell counts and differential cell count. Normally, leukocyte count is less than 200 cells per cubic mm. Newborn counting chamber is used for cell count. Neutrophils are less than 25% and lymphocytes are less than 15%. Normally, crystals are not present. In septic arthritis condition, increased neutrophils occurs. Increased cell count with increased lymphocytes are seen in the non-septic inflammation. Proteins are usually found in the plasma with some amount of fibrinogen and alpha to beta 2 macroglobulins are present in the synovial fluid. Normal range of protein is less than 3 grams per deciliter. Increased protein is found in the ankylosing spondylitis, arthritis, Crohn's disease, and psoriatic arthritis, Ritter syndrome, and ulcerative colitis. Normally, glucose levels are less than 10 milligrams deciliter lower than the blood glucose. Glucose levels are decreased in septic and inflammatory joint disorders. Uric acid levels are normally 68 milligrams per deciliter. These are increased in the gouty arthritis. Lactic acid is helpful in the diagnosis of septic arthritis. Normal range is 25 milligrams per deciliter. In septic arthritis condition, levels are raised up to 1000 milligrams per deciliter. Lactate dehydrogenase is elevated in the synovial fluid in case of rheumatoid arthritis and infection arthritis and gouty arthritis. Rheumatoid factor is the antibody to immunoglobulin present in the rheumatoid arthritis. Elevated more than the 50% in the synovial fluid indicates rheumatoid arthritis. False positive conditions occurs in the with the other chronic inflammatory diseases. And in systemic lupus erythematosus, LV cells and TART cells are seen. LV cells are lupus erythematosus cells are neutrophils that have engulfed with the nucleus of the lymphocyte. TART cells are monocytes that have engulfed with the nuclear material. Ritter cells present in the Ritter syndrome. These are vacuolated macrophages with ingested neutrophils. And RA cells and rhagocytes are present in the rheumatoid arthritis. These are neutrophils with small inclusion bodies with precipitated rheumatoid factor. Hemosiderin present in the pigmented villonodular synovitis with inclusions within the clusters of the synovial cells present. Rice bodies macroscopically appears as a polysaccharide, microscopically shows a collagen and fibrin material. Monosodium urate crystals are seen in the gout, calcium pyrophosphate crystals are seen in the pseudogout, and corticosteroid crystals are appears in rheumatoid arthritis and recent corticosteroid injection in the joint. Cholesterol crystals are in the rheumatoid arthritis. And microbiologically, staining of the synovial fluid by smears preparing by centrifugation and cytocentrifugation. Saline dilution reduces the clustering of the cells. So gram stain is most commonly used for the staining purpose. And cultures are set up with the positive and negative strain results and the aerobic and anaerobic results. Normally, synovial fluid is colorless, clear fluid with high viscosity with good motion clock. WBC count is less than 150 cells per cubic mm and with less than polymorphonucleosides are less than 25%. And non-inflammatory, it appears as yellow cloud, slightly cloudy in nature. Inflammatory white color cloudy in nature. Septic arthritis white color green cloudy purulent appearance. In crystal induced arthritis, it appears like white cloudy turbid opaque milky in nature. Xanthochromatic red brown color is appearance in the hemorrhagic conditions. With viscosity is low in the inflammatory and non-inflammatory synovial condition. Septic arthritis with mucin clot is pure and more than 90% of neutrophils increasement, and synovial blood glucose is more than the serum with positive blood culture. Synovial fluid aspiration helps in the classification of the joint disorders. Joint disorders classified by inflammatory and non-inflammatory, pathologically by degenerative joint disorders like osteoarthritis. Immunological disorders are rheumatoid arthritis, scleroderma, poliomyelitis, and ankylosing spondylitis with rheumatic fever and Lyme disease. Crystal-induced arthritis are gout and pseudocoque. Septic arthritis are due to microbial infection. Hemorrhagic arthritis is a traumatic injury or tumors, hemophilia, and other coagulating disorders, or in case of anticoagulant overdose. Finally, synovial fluid analysis is a well-established procedure for evaluation of the joint disease, and it determines the presence of arthritis and assists in the classification of joint disorders. And it helps to guide the appropriate treatment procedure.
Excellent presentation. Stop sharing your screen. Gopakumar sir.
Sir, thank you, sir.
Sir,
Gopakumar sir, your comments please. Stop sharing the screen.
Yes, sir. Yes, sir. I'm unable to start this.
Samantha sir is left. Mohanty sir.
Yeah, good presentation, but you are just reading the slides. You should be a little bit, describe those slides rather than going through reading the slides. Some disturbance. Okay. And you did not tell so much thing about synovial fluid analysis when you are talking about monoarticular arthritis. You should have a practical approach to monoarticular arthritis. Okay, how to diagnose it, how to do a differential diagnosis, then give a overview of different types of monoarticular arthritis, which you started with that. Did not describe so much in detail. That is another lecture altogether about synovial fluid and what is the composition, how it will alter in detail. So it was a little bit lengthy in terms of that because you described about synovial fluid. But otherwise, monoarticular arthritis part, it covers only the differential diagnosis. Most of the time you will get a case also in monoarticular arthritis and how to do a differential diagnosis depending upon the age, the presentation, and acute or chronic, and whatever, and any associated findings. So overall it was good, could be better also. Thank you.
Okay, sir. Thank you, sir.
Mohan,
Sir.
you should have practice of presenting cases in your own institute. You have problem of expression.
Okay,
Even if
sir.
you know the things, you may not be able to express unless you will keep practicing. And your topic, as Mohanty sir has told, practical approach, monoarticular disease, then how will you go about it in examination?
Okay,
and I will reach to the conclusion with possible means
okay,
differential type of thing should be. You have tried to
Yes,
cover the topic, and most of the topic unfortunately was cut, copy, paste with just reading. So understanding the topic and then putting the words becomes very easy when you know the concept. Okay. So our aim of presenting the topics here or giving you people task is to teach you clear, concise, concept based learning. Clear?
Yes, sir. Yes, sir.
Kanuja sir.
Yes, he has done hard work, but as Mohanty sir has said, the practical approach, monoarticular, mainly we are getting this. Theoretically, you can express, but theoretically it was too much, which we don't do in practical things.
Sir.
If it comes to your clinic, an examiner will ask, what will you do? How will you differentiate? And monoarticular, mainly synovial fluid, just like I was saying, that if it is infected, the sugar level will be reduced or there will be no. Inflammatory sugar level will be same. Same way, there is a exudate and transudate, where you can know that what type of inflammation is there. Traumatic, infective, or inflammatory. These are few things which are very important, because once we send the synovial fluid, we want to know most of the diagnosis. And then more about biopsy, if it is to be done.
Okay, sir.
Otherwise, you have done hard work, but then initially I told, no,
Sir, yes.
you should understand whatsoever you are saying. Like if you are saying drug abuse, how it will happen. Same way you said in septic arthritis, I give IV fluids.
In case of septic shock for treatment, stabilize the patient. In
A
case.
patient is in septicemia almost,
sir.
or
Okay.
when
sir.
inflammation is there.
Okay, sir.
So to control that, so whatsoever you are saying, you should know it
Sir.
why you are saying, how
Okay,
much
sir.
it is important. So
Okay,
next
sir.
time you
Yes,
can
sir.
do better. You have worked hard, but then first understand
Yes, sir.
and then tell. As Monty sir has said, you should have said total by slides. This is this, this is this.
Okay, sir.
Read less.
Yes,
Okay.
Yes, sir. Yes, sir. Thank you, sir.
So, what is concise, clear, and concept-based hints given by Mohanty sir and Kanojia sir? Hard work is okay. Smart work is better. And smart work with understanding, target-oriented,
Okay, sir.
is expected. That is the best.
Okay, sir.
Uday Kumar sir,
Okay, sir.
your comments. I think Uday Kumar sir is not there. Mohanty sir, your concluding remark, and then we will close the today's session.
Yeah, let's close the session. I think we have told enough for him. And next time we'll hear from the next, whatever homework has been given. Today it was a nice class. I think many students have joined today, 66 or something like that. I was seeing the peak time attendance.
Sir.
Okay, you should more and more students should join. These are the clinical cases. When it is presented, the clinical oriented questions are being asked. So you should tell your friends, maximum people should take the advantage of attending these clinical case presentations, and then followed by little discussion. This is the good format and we should follow this in future. Thank you.